late. That's great, but they missed out on stuff, and that's sad. So, once again, we have Dr. William Lile, who has graciously decided to give us take two. We had some issues last month that we won't get into too mean details about, but we're going to do this again. And I appreciate it once again, Doctor. And I always let you introduce yourself because you're better at it than me. And I've heard some of your speeches, and I can relate. It seems like you make sense to me, so I really appreciate that. Without further ado, Dr. William Lyle.
Well, good evening, everybody, and it's an honor to be with y'all. Whenever somebody wants some new tools to equip them to better defend the baby in the womb, I'm all on board. And this is how we work as a team to really fight evil. So I'm going to give you some excerpts from what we've titled the Abortion is Not Healthcare Tour. This is a college tour that we're taking around the country. I've spoken at the University of West Florida, Texas A&M, let's see, University of Georgia, University of Tennessee, trying to provide the students with some of the same tools that we're going to share tonight. So that is the Abortion is Not Healthcare Tour. And one of the key parts of the Abortion is Not Healthcare Tour is discussing patients' rights. I mean, all 50 states have laws that protect the rights of patients, and all of us have at some time in our lives been a patient. All 50 states have these laws that protect the rights of patients, so we're going to apply some of those laws tonight. Healthcare is in a state of flux. I mean, we thought that healthcare was going to be changing for the better because of AI. AI is going to be changing our lives in so many ways. And we really had this vision that computers will be diagnosing and even treating people. We had visions of the diagnostics coming up and the doctors talking to robots. It's like, this is what I need you to do. In fact, we had data that showed that when AI was reading a mammogram, in a lot of cases, it was better at detecting cancer than a board certified radiologist. And it's using technology to improve healthcare. And we were celebrating doctors, nurses, techs, we're all celebrating. And then somewhere along the way, with all this great technology, the government got involved. And when the government got involved, efficiency went down, delivery of healthcare went down. And we had men that were in chaos. We had women that were facing chaos. We had men that said, what the heck is going on? I had insurance. Why can't I get anybody to help me? Women were just staring and saying, how do I get somebody to help? And then we'd even have insurance and we'd get the bill. It's like, I've got health insurance. How is my bill $30,000 for a visit to the emergency room? And people started to get angry. They said, hey, healthcare is a human right. I'm a human. I deserve human right as a healthcare. And they started to get upended. And we started to see there's a lot of problems, but we have areas of hope in our healthcare delivery. Some areas of healthcare have actually been improving. And where do I see that hope? A lot of that hope is what I was seeing in my practice. And that practice is obstetrics and gynecology. And things that are going on now in healthcare were something that wasn't even conceivable and even believable back when I was in my training. We have now had tiny, tiny babies. This is the world's smallest baby that was ever delivered. The baby was delivered in Iowa, was 21 weeks and 0 days, had great doctors, great nurses, great respiratory therapists, and the baby survived and is home and is doing well. That baby only weighed 10 ounces at delivery. And it's like, well, 21 weeks. Well, what's term? Term is considered 40 weeks. That is your due date. This baby only weighed 10 ounces at delivery, and that was in Iowa. But just north of me at the University of Alabama, Birmingham, we had a baby that was delivered at 21 weeks, 1 day. And that baby's name was Curtis, and that baby only weighed 14 ounces. And again, that baby did well, spent about a half a year in the intensive care nursery, but went home and is progressing well. We see tiny little twins that have breathing machines hooked to them, and then they grow and they are perfectly normal babies. We see tiny little babies with this. We're starting to get some little curly hair on the top that's actually holding her own portrait. Again, born preterm, but technology, dedicated doctors and nurses are saving the lives of these babies. This is a baby named Haley. You can see she has a breathing mask on. She was preemie and struggling to breathe. Now, of all things, Haley's actually a nurse working on the pulmonary care unit of her hospital. So just because somebody is small doesn't mean that they don't have value. We don't get more value as we get bigger and even way more. Going to flash it back to 1999. And no, I'm not going to sing any of the music from 1999, but this is the practice that I took over when I finished my residency at the University of Florida in 1999. We took over the practice. It was not a great investment because he hadn't performed any deliveries or any obstetrical care for years, but it was on a good location right near the hospital. But the reason that it attracted my attention, because this was the largest provider of abortions in the Pensacola region for the past 25 years. So we didn't telegraph our, messaging what we took over the practice. We had him sign a restrictive covenant, a non-compete, where he couldn't practice any form of medicine for the next 2 years in our tri-county area. We took over the practice. We sat down with the staff on day one and we said, listen, we're the new bosses, we're the new guys in town, and things are going to change. And you're welcome to stay. But from now on, we are no longer going to perform any abortions. And if somebody schedules somebody or even refers somebody for an abortion, that would be grounds for termination. I didn't know what the response was going to be. Every one of the staff members had a big smile and they stayed with us for years and years and years. In fact, the nurse, her name was Anne, and Anne was an LPN. And as an LPN who'd been there for decades, she felt that she could not get another job at any of their hospitals, and none of our other regional hospitals would hire an LPN. Anne's job was to take the products of a surgical abortion, and her job was to not only clean up the equipment, but actually reassemble to make sure that all of the parts of the baby had been retrieved and delivered during the abortion. She stayed with me until she retired, and she really felt that we had brought her out of, she considered it to be a really dark area of her life. And that's also when we developed the ministry of prolifedoc.org, where we are trying to use science to equip people. I don't want the abortion debate to be whoever yells the loudest or whoever is the angriest or the more threatening wins a discussion or a debate. I want to win on the merits, and the merits that we're going to be discussing tonight are science. So that is our website, and we are a 501c3. But for tonight, we're going to have this group, this organization take you all to med school. So tonight, we're going to take you to the Pro-Life Doc School of Medicine. And one of the first things that anybody who goes into medical school or nursing school learns is a little bit of Latin. I mean, I can't speak fluent Latin. I can't even Latin dance. But when it comes to Latin, the first phrase that we're all taught is this one, which is primum non nocere, which when you translate it to English, it means first, do no harm. You're in med school. You're going to be a doctor. We're going to give you scalpels. We're going to give you needles. We're going to give you radiation, chemotherapy, x-rays, ultrasound. These are all tools to heal, not to harm. So rule number one, when you're dealing with any patient, is first, do no harm. The second thing is that patients have rights. All 50 states have laws which protect the rights of patients. And you might be the physician, but your job is to educate. Even when it comes to operating on somebody, your job is to give informed consent, where you explain the risks, benefits, indications, and alternatives to the patient. Let them have all that information and make the decision that is best for them and their bodies. When it comes to patients' rights, yes, we celebrate the fact that we all have patients' rights. I was discussing patients' rights recently at the University of Florida. I'm board certified in obstetrics and gynecology. I've delivered over 5,000 babies during my time here in Pensacola. I've been an instructor with both the University of Florida and instructor with Florida State. I was the vice chair of the Department of Obstetrics and Gynecology at my hospital, and I was the president of the and chairman of the Department of Obstetrics and Gynecology. So I was lecturing at the University of Florida over in Gainesville. I asked the students, I said, If I have a patient that is down in the emergency room and that patient needs a blood transfusion or they will die, but that patient wasn't born in the United States, do I still have a moral and legal obligation to provide this life-saving procedure, a blood transfusion to this patient who needs it, even though they weren't born in the
Yes.
United States? Absolutely, yes. In fact, one of the students stood up in the back of the room and he goes, Dr. Lyle, we've been taught here at the University of Florida College of Medicine that a patient is a person is entitled to respect and bodily integrity. And yes, you have a moral and a legal obligation to provide that patient with a life-saving blood transfusion. And it doesn't matter if they were born in the United States. I said, I agree with you 100%. I was taught the same thing when I was here at the University of Florida. And I said, and just so you know, the patient that was down in the emergency room that needed a life-saving blood transfusion received that life-saving blood transfusion, even though they weren't born in the United States yet. And the student's like, what are you talking about yet? I said, because we are now giving life-saving blood transfusions to babies in the womb, even while they are still on the inside of their mother. And it's called a pubs. I mean, I like pubs. I mean, we just had St. Patty's Day a couple months ago. Pubs are good, but this kind of pubs has nothing to do with getting a cool Guinness at that with your friends. A pubs is a peri-umbilical blood sampling and transfusion. Because yes, we are giving babies life-saving blood transfusions. We've done this at my hospital as early as 18 weeks gestation. The Cleveland Clinic recently gave a life-saving blood transfusion to a baby in the womb at 17 weeks gestation. Well, why would a baby even need a blood transfusion? Because from the moment of conception, that baby is genetically unique. Baby's genetically unique from the mom, genetically unique from the dad. In fact, that baby is genetically unique from the other 8 billion people on the planet. And that baby can even have a different blood type than that of the mother because moms and babies, they have an intimate relationship, but they don't share the blood. In fact, the baby's blood goes to the placenta and everything the baby needs, it gets from the mom. And everything the baby needs to get rid of, it gives back to the mom, and then the mom will eliminate that. So when they have different blood types, there are certain, occasions and certain circumstances where because they have different blood types, moms will develop antibodies which can cross the placenta and actually start to attack the baby's blood. And the baby's blood count starts to drop. And if we don't do something, just like an adult like me, whose blood count starts to drop, they can die. Well, how do we even know that babies have a low blood count? We actually do an ultrasound. We can do an ultrasound of something called the middle cerebral artery in the brain, look at the speed of individual red blood cells going through that. And if it's really fast, there's a problem. Just like if there are only 5 people in a movie theater and there's a fire, those 5 people can get out real quickly. But say we have 500 people in a movie theater and there's a
Oh, get
fire,
out from there.
they're not going to be able to get
You're
out
not
quickly.
supposed to be there.
I'm not sure if anybody else is hearing that, but when it comes to when we see that the baby needs a blood transfusion, we could take a unit of your blood, somebody that donated O negative blood, we put it in a syringe, we guide that syringe with an ultrasound, and we go right into the umbilical vein, and we can give that baby a life-saving blood transfusion. Sometimes we have to do that every 3 or 4 weeks because the mom doesn't want to hurt her baby, but her immune system is attacking her baby. So if we can do a life-saving blood transfusion to a baby while it's in the womb, is that a patient? Yeah, of course. All patients have rights, and a patient is a person, no matter how small. This is an animation that we created ourselves of how we do this blood transfusion. So here's a baby that is anemic. Mom's immune system is attacking. You can see the ultrasound probe up there at the top, and we're going to guide a needle right through the skin of the mom. We're going to take that needle, guide it with ultrasound guidance, and go right up to the umbilical cord. We can see that there are 2 arteries and there's 1 vein. The arteries are taking unoxygenated blood to the placenta, and that single vein is bringing oxygenated blood back to the baby. So we're going to show you that blood flow, and we can see the arteries, and we can see the vein, and we can see the tip of the needle. and we can guide it, avoiding the baby, avoiding other problems. And we don't just go to the umbilical cord. We specifically will guide that tip of the needle right into the umbilical vein. So you're going to see right there at the left side, that is the tip of the needle, a special needle called a Huber needle that has just gone into the side of the umbilical vein. And now we're given a blood transfusion to that baby, somebody's blood who's O negative blood that one of you might have donated. And sometimes we'll repeat this every 3 or 4 or 5 weeks. So again, if we can give them a blood transfusion, they're a patient. A patient's a person, no matter how small. But then there's something called twin transfusion syndrome, and it occurs with identical twins. But what's special about these twins is these twins are sharing one placenta. If we looked in closely, you have a twin over on the left side and a twin over on the right side. One egg, one sperm that combined, and then before day 13, actually divided into two identical copies. But these babies happen to be sharing one placenta. Well, why is the one on the left real big and the one on the right real small? Because they are not sharing equally. So we're just going to call this kid Arnold, call this kid Danny. And now it makes sense. That movie Twins, it was twin transfusion syndrome. Well, when we do an ultrasound and we see that one baby, and we know they're identical twins, when we see that one baby is up at the 98th or 99th percentile, and its identical twin is down at the first percentile, what do? Well, if the little baby dies, then the big baby's going to die because they are sharing one life support system. So what do? We send the mom and her twins down to Texas Children's Hospital. Why? Because they will go inside of the womb, go make an incision right in the skin, go right inside the womb with a fetoscope, a camera where they can not only look at the babies, but they can look at the placenta. And then they take a laser, just like Austin Powers, a laser, and they will take that laser and they will divide that placenta going right through all those blood vessels. They'll divide that placenta in half, saying, Arnold, this is your side of the placenta. Danny, this is your side of the placenta. They watch them for 10 days after they've taught them how to share. And after 10 days, they send them back to us. They've done this as early as 21 weeks gestation. We receive the mom and the babies back at our hospital in Florida, and we follow them for the rest of the pregnancy. One baby might have been at the 99th percentile and the other at the first or second percentile, but by the time we deliver them, after we've taught them how to share, they might be 60, 40, 70, 30. So if we can teach babies how to share while they're inside their mother's womb, they are definitely a patient. And there are laws in all 50 states that protect the rights of patients, and a patient is a person, no matter how small. I'm not sure if any of you have seen this photo before. It's a famous photo taken by a friend of mine named Michael Clancy. What's the background? Vanderbilt University was conducting a trial called the MOMS trial, where they were diagnosing babies with spina bifida while they were still inside the mother's womb. And when a baby has spina bifida and nothing is done until after the babies are delivered, a lot of these babies, they can't walk. They have no control of their legs. They have no control of their bladders, no control of their bowels. This will affect them for the rest of their lives. So the doctors at Vanderbilt said, what if we were to go on the inside, repair the defect in the baby's spine while the baby's on the inside, and then allow it to heal? Will these kids do better? Well, what they have found now that they've been doing this for over 25 years is that when they take the initiative and they take the risk and they discuss the pros and the cons with the parents, when they take the initiative and they will make an incision in the mom's belly and then bring the uterus out, make an incision in the uterus itself, and then perform the surgery on the baby's spine, that 25 years later, we know that these babies that were operated on in the womb, rather than wait until after they delivered, they can go upstairs faster. They can go downstairs faster. They have better control of their bladders, better control of their bowels. They have fewer additional surgeries. So if we can change the quality of life for a baby for the rest of its life by operating on that baby while the baby's still in the womb, is that a patient? Absolutely. All patients have rights, and a patient is a person, no matter how small. This is a surgery of a baby that was having spina bifida corrective surgery. They're doing spine surgery, but for some reason, this baby decided to stick his hand out. He grabbed onto the finger of the surgeon, kind of gave him a little high one, and they made a little contact, and that baby did very well with the surgery. It was called the MOMS trial, and they're still undergoing this surgery and this trial because they know they can actually improve the quality of life of these babies. I was speaking at Georgia Right to Life years ago, and this kid came up to me. He goes, Dr. Lyle, he said, you use my picture all the time. And I said, what are you talking about? And he says, that baby, he says, that's me. And if you look at his name tag, it says Samuel Armas. And I said, Samuel, it is a pleasure to meet you. I said, I got a question for you. I said, when you were inside of your mother's womb and they did surgery on your spine, I said, Samuel, were you a patient? And he stops and he goes, well, duh. I said, well, I agree. Clearly, you were a patient. You are a person. It's a pleasure to meet you. Now I need you to tell your story so that other people know that you were a patient inside your mother's womb and you had rights. This is Samuel now. Samuel just recently graduated from Auburn University. So is Samuel a patient with rights there at Auburn? Absolutely. Was Samuel a patient with rights when he met me at Georgia Right to Life? Yes. Was Samuel a patient with rights when he was inside his mother's womb getting surgery? You better believe it. But now that same surgery is being done with a fetoscope, where instead of making a big incision in the mom's belly and making an incision in her womb, we're performing this same surgery with a scope. I don't know why, but my computer just locked up. I don't know why. Gentlemen, am I still sharing with y'all?
You just stop sharing.
Okay, I just stopped sharing. Let me just pull it
Just
right back up. And I'm going to pull it right back up and I'm going to go back to sharing because I don't know why it just locked up. Okay, here we go. So I'm going to go back to where we were. I'm not sure why it, but we're now doing this with a scope. And this is a mother's uterus who's been exposed. And we've taken the scope and we've actually placed it inside the woman. I'm going to give you a unique view because ultrasound is a great tool, but this is what a baby really looks like on the inside. That is not a blob of tissue. That is a patient. That is a baby. You can actually see the umbilical cord and you can see those little blood vessels there on the surface,
hey,
which is what they
doctor,
would laser. Yes.
we can't see your screen.
Okay. Let me do a little share.
Try to
Uh,
share.
yep. I'm going to share. I'm going to expand this and I'm going to share. How about now? Are y'all seeing it?
So we see your desktop.
Okay, great. And bam. So let me just show you what I just
There we
described.
go.
Are you seeing that? Great. So this is the mom's womb, her uterus. They've made an incision in the skin. They brought the uterus out and they've placed a fetoscope on the inside. But then they're going to place instruments. But this is not a blob of tissue. This is so much better as far as imaging. A tiny child could recognize that that's a baby on the inside. So it's not a blob of tissue. This is a patient. This is a patient that I would see. And if they are a patient, they are a person. But now there's a cure trial that's going on at UC Davis where they're actually not operating and just trying to repair it. They're actually using stem cells. This is Dr. Diana Farmer. They got a $20 million grant for this, study, and they just got a second $20 million grant for this same study because they really are showing evidence that when they use stem cells to place on the defect on these babies' spines, that they can actually cure spina bifida. In fact, I'll show you the surgery. This is just another animation that we produced for educational purposes, but this is the mom. They've already done the ultrasound. The baby's been referred because of this defect. That is spina bifida. In the yellow there, that's actually the baby's spinal cord. So on the day of the surgery, mom had an epidural, so she's wide awake. They made an incision in the mom's belly, made an incision in the fascia, made another incision in the womb itself. And now you can actually see the baby there on the inside. And this is the defect. So they take instruments on the inside. They're going to undermine the skin, loosen the skin so that they can actually do the surgery. And then they have a thin layer called the arachnoid that they're going to separate to the right and to the left. And they're going to take that exposed spinal cord, they're going to place it back on the inside where it was supposed to be. They're going to then go layer by layer to close it up. But before they close the last layer, they take stem cells. Stem cells are called totipotential cells because these have the potential of becoming any kind of cell. They just need some guidance and direction. So when they surgically place these stem cells on the spinal cord layers, the stem cells kind of wake up and they go, now I know what I want to be when I grow up. And they start to develop normal spinal cord tissue and heal it like no surgeon could ever do. They close the uterus, close the skin, and they deliver the baby at term. So if we can actually cure spina bifida by operating on the babies while they're on the inside, is that baby Robbie a patient? Yes. And a patient's a person, no matter how small. Of all the examples of surgery of babies in the womb, this is my favorite, and this is the one I really want you to remember. We are now doing open heart surgery for babies while they're still on the inside of the womb. This was a baby that at 27 weeks gestation was diagnosed with a cardiac teratoma. What's that? The baby had a tumor on the baby's heart. So they gave the parents the options. We can deliver the baby and then operate on the baby. But now we have a 27-week preemie that's got a fixed heart, but is struggling to breathe. They said, option number two, we'd like to give you anesthesia and actually operate on the baby's heart while the baby's still on the inside. Let the baby continue to grow and develop in the best environment possible, which is inside the womb. The baby's heart is at that gestational age is about the size of the end of my thumb. That tumor that was attached to the heart was about the size of my thumbnail. The tumor was growing so much quicker there at that gestational age that they said, this baby's going to die in 1 to 2 weeks. So parents decided, let's operate on the baby on the inside. So at the Cleveland Clinic, you go to 6 Northwest, and I love this picture because even though this is maternal fetal medicine, this OR, because the primary patient is the baby, it's called the fetal OR. Mom and baby both go into this room and amazing surgery is done, but it's referred to as the fetal OR. And this will give you an idea. So this is an ultrasound. You know, around the outside, that circle, that's the baby's chest. And then on the inside, on the right and the left, you can see lungs. And then when you see down there at the bottom, that is the heart. You can see the ventricles and the atria. Well, what's this goomba up here? That's the tumor. That's the cardiac teratoma, which was pressing on the baby's heart, which was what was going to kill that baby. This is the actual OR team. 36 doctors, nurses, circulators, and techs, which aren't even shown, that are taking care of the mom and the baby. This is healthcare at the highest level. But what's really interesting is how many anesthesia teams did they have? They had 2 anesthesia teams. There was actually an anesthesiologist for the mom, and the mom had an epidural, so she was comfortable but wide awake. They had a completely separate anesthesia team just for the baby. So when it came to the day of the surgery, mom had an epidural, she's wide awake, made an incision in her skin, made an incision in her womb. They brought up the baby's right hand, brought the baby's left hand, and then the pediatric anesthesiologist started that IV in the baby's hand, not just so the baby could get some fluid. They were actually continuously dosing that baby with a powerful narcotic called fentanyl and then another medication called Norcuron. What's Norcuron? Norcuron's a paralytic because when you're doing open heart surgery, you don't want the baby moving around. So they had a pediatric anesthesiologist who for over 3 hours was dosing that baby to keep that baby comfortable while it was having open heart surgery. Again, this is an animation that we developed just to show the amazing advances and provide everybody with tools. Here's the baby on the inside. You can see that the baby has a beating heart. The heart was beating about 120 times per minute during this entire surgery. But see that kind of golf ball looking thing that's on the heart? That's the actual heart tumor. So day of the surgery, mom has an epidural. She's perfectly comfortable, made an incision in the mom's belly, made an incision in the fascia, made a third incision through the uterus. And then they brought the baby's right hand and the left hand. Then they said, pediatric anesthesiologist, your turn. Pediatric anesthesiologist started the IV. Cardiothoracic team came in, made an incision in the baby's chest, opened the baby's chest. It took them 3 hours, but over 3 hours, they successfully removed that tumor from the baby's beating heart. The heart went, thank you very much. Baby went, thank you very much. They then removed the IV, they tucked the arm back on the inside, they closed the uterus, closed the skin. They didn't deliver that baby until 37 weeks gestation. The surgery was done at 27 weeks, but they didn't deliver that baby for 10 weeks later. So if we can do open heart surgery for a baby on the inside of the womb, where the baby actually receives its own anesthesiologist, is that a patient? You better believe it. And that's Rylan after the surgery. And that's Rylan a couple months after the surgery. And that's the most recent picture that I happen to have of Rylan. And if you look at Rylan's chest, you can hardly see any scar tissue. Why? Because baby Rylan was still growing and developing when he was inside of his mother's womb. Do babies feel pain? Yes. That's why they had a pediatric anesthesiologist to make sure that this patient was comfortable. But we're correcting heart arrhythmias as well. This is a condition called fetal supraventricular tachycardia, fetal SVT. Big word. What does it mean? It means that instead of the baby's heart beating 120, 140 beats per minute, these babies' hearts will but beat maybe 250, 260, 270, way too fast. And if something isn't done, these babies will die from heart failure. So you can deliver the baby and give the baby medication to correct that. But what do you do if the baby's only 22 weeks along? Babies can't survive hardly ever at that gestational age. Well, we give them the medication while they're still on the inside, and it's called adenosine. And we do this routinely. It's a heart medication that will stop the heart. And here's the mom and here's the baby on the inside. The audio is not working over the internet, but the heart rate you can see is about 270 beats per minute. So what we're going to do is we're going to treat it just like your phone. If your phone stops working because you have too many apps open, we all turn off our phone, reboot it, and restart it. So we'll actually guide a needle, just like with the blood transfusion, guide it through the skin, through the wall of the uterus, and we go right into the umbilical vein, and we actually get this baby a medicine called adenosine. Adenosine goes through the umbilical cord, goes right up to the baby's heart, and it will stop the baby's heart for 5 seconds. The heart depolarizes, then repolarizes, and when it boots back up, it almost always comes back at a normal rate. So if we can do open heart surgery and if we can do, medical therapy for a heart arrhythmia, is that a patient? Yeah, but it gets cooler. This is the baby who was diagnosed with something called a Galen malformation. If you look at this, a Galen malformation is when you have an abnormal connection between a high pressure artery and a low pressure vein. And it's not meant to be there. So the veins aren't designed to handle high pressure. And you can see where it says VOGM, that's a vein of Galen malformation. And this vein is so swollen that it's getting ready to rupture as a ruptured aneurysm. When we diagnose the vein of Galen malformation, half of these babies right after delivery get really sick. And of those babies that get sick, half of those patients die. So nobody likes having 25% of their patients dying. So doctors up at Boston Children's Hospital said, we don't like our patients dying. What can we do? Why don't we work on developing a therapy where we can treat this while the baby's still in the womb? And that's exactly what they did. And this is another animation that we developed of a Galen malformation. So the baby is on the inside. They've already numbed up the baby with a little bit of anesthesia. We're using an ultrasound. They're going to take this trocar, guide it through the skin, through the wall of the uterus. They go right into the back of the baby's skull. Now remember, the brain does not have pain fibers. So when the needle goes into the baby's brain, the baby doesn't sense that. But here's the problem. You have a high pressure artery and a low pressure vein, and there's an abnormal connection between the two. So the doctor said, we need to build a wall between the high pressure artery and the high pressure vein. So here they're introducing tiny little vascular coils, and they're building a wall brick by brick. What didn't work on the first coil, second coil, or third coil, but by the time they'd introduced a fourth vascular coil, they'd actually built a wall, they delivered that baby, and that baby is doing great. In fact, that's baby Denver. Baby Denver had vascular brain surgery while baby Denver was still in its mother's womb. So if we can do vascular brain surgery for a baby while it's in the womb, is that a patient? Absolutely. And a patient's a person, no matter how small, and all patients have rights. That's a follow-up picture of baby Denver, and that's the most recent picture that I have of baby Denver. This is a patient. This patient deserves protection. This is Dr. Sanjay Gupta. I don't have the audio that we can show through the internet, but I want to let you see what they were actually doing. So Sanjay Gupta, he's the medical director and correspondent for CNN. And he heard about they had done a Galen malformation for a baby while it was inside the womb. He's like, get me a film crew, get me a van. We're going to Boston. He actually interviewed the doctor. And this is Dr. Sanjay Gupta. He's talking about inside of the womb. And he said when they take two patients to the op room instead of one. So this is them actually taking that catheter and they're threading that catheter. And now they're introducing these vascular coils on the inside. And this is Dr. Gupta, and that's the surgeon on the right side. So if we can do vascular brain surgery for a baby on the inside of the womb, that is a patient. And words matter. By definition, what is a patient? A patient, by definition, is a person receiving medical treatment. I mean, we just spent 20 minutes going over the different advances on how we are diagnosing, treating, and curing babies in the womb. So if they are receiving medical treatment, then they are a person. And what's significant about person is that the 14th Amendment says, nor shall any state deny any person of life, liberty, or property. So if they are a patient, they are a person. If they are a person, then they deserve protection. This is a question we often get at the medical schools and at the colleges when we're doing our tour. They want to know, well, what about the mother's life and health? Is abortion ever medically necessary to save the life of the mother? No. I mean, are there reasons for early delivery? Absolutely. You know, the babies that are delivered at 21 weeks and surviving, there were conditions that were going on where the mother's health and life was being threatened. But it's the delivery of the baby with situations like severe preeclampsia or maternal cardiomyopathy. These are caused and aggravated by the pregnancy, but it's not the stopping of the baby's heart that provides health care and sustaining life for the mom. It's not killing the baby, it's delivery of the baby. So kill the baby? No. Deliver the baby? Yes. And now we have babies with our current technology which are surviving and thriving when they're less than a pound and being delivered at a young gestational age. Let's talk about the abortion pill. I heard one of the gentlemen talking today about, I love the description of the program that he was, and this, it was 100 pages of educational information he was describing. I'd love to get a copy of that. But let's talk a little about the abortion pill, also known as mifepristone. This is the most common form of abortion here in the United States. There are companies like Aid Access, which will ship the abortion pill to all 50 states. And these women are not getting an ultrasound. They're not getting a diagnosis as far as how far along they are. And those are what the people get. They get the abortion pill, and then that's the pill in the middle, and they get a bunch of pills on the outside, which cause contractions. And it will kill a baby in the womb between 10 and 12 weeks gestation, 98% of the time. That's not healthcare if we're taking the life of a baby that has fingers and toes, fingerprints, and a beating heart. But this is also dangerous for moms as well. There was a study that was produced on April 28th of last year. They looked at the healthcare records of 865,000 women who were prescribed the abortion pill. Non-biased, here's the prescription. Let's follow them for 45 days and see how they did. What they found were, number one, over 40,000 of these women had to go to the ER. 28,000 women had to be treated for hemorrhage and bleeding. 24,000 women needed additional surgery, like a D&C to remove leftover placenta or leftover baby parts. 12,000 of the women had to be treated for infection or even sepsis, and over 3,000 women had to be treated for an ectopic or tubal pregnancy. Ectopic or tubal pregnancy is still the number one pregnancy-related cause of death of women in the first trimester of pregnancy. In fact, my daughter got treated for an ectopic pregnancy by one of my partners just 3 weeks ago when we were out of town. So when a woman has a positive pregnancy test and doesn't have an ultrasound, between 1 and 2% of those women will have an ectopic pregnancy. Those are the statistics. So when a woman is given the abortion pill, there's a 1 to 2% of that woman who has a positive pregnancy test, that 1 to 2% of those women will have a tubal pregnancy. That is not healthcare when not just are there increased risk, but we were told with the abortion pill that women would have a complication less than 0.5% of the time. What does this study, which is 28 times larger than all the studies that went towards the approval of the abortion pill, what does this study show? It shows that it's not 0.5%, it's 10.93%, 22 times higher than what we had been told. And yes, it'll kill a baby. That's a graphic over on the right, and that's actually an ultrasound of a baby, what a baby looks like at 10 weeks. But the abortion pill is readily available up through 12 weeks gestation. It's widely used. In fact, estimates are that at least 70% of all the abortions in the United States are performed with the abortion pill. That's over 750,000 abortions with the abortion pill just last year. How does it work? It blocks a real important hormone, and that's called progesterone. Big word. We'll break it down. You're in med school. We take a big word, we break it down to little pieces. Progesterone is the progestational steroid hormone. Everything that's good about a pregnancy is because of progesterone. Progesterone is the signal that says, hey, body, wake up. We are pregnant. We're not going to have a menstrual cycle. We're going to relax the uterus so it doesn't contract. We're going to divert more blood supply to the uterus from the rest of the body. The abortion pill blocks that hormone called progesterone. So here's a positive pregnancy test. That's HCG. What does progesterone do? It goes up. Normally, when a woman is not pregnant, progesterone goes up and then it goes down, and that's what causes a menstrual cycle. But a woman has a positive pregnancy test, that hormone progesterone goes up. But say the woman is, feels pressured, say she's even forced, and there's cases that are growing of women who are actually being slipped the abortion pill. In fact, I just met a young lady in Texas who was slipped the abortion pill in a hot cup of hot chocolate by her boyfriend because she wanted to have the baby, but he did not. She didn't want to have an abortion. And they even found a credit card receipt of him purchasing the abortion pill. So when somebody takes the abortion pill, the progesterone levels go down. And we have about a 72-hour window where that baby will die in the next 1 to 2 days. But what if the mom changes her mind? She goes, what the heck did I do? I didn't want to do that. I mean, I've got a fast mouth. I say things all the time that I didn't mean to say. I've done things that I didn't mean to do, and I get regrets. And it's just part of being human. We have regrets. Well, what do you do if a mom's already taken the abortion pill? Well, we can actually give her progesterone and bring the progesterone levels back up. We have a network of over 8,000 doctors that we've trained on the protocol to use bioidentical progesterone that comes in a bottle. That's progesterone. It is the exact same chemical and structure to the bond, the carbon bond of the progesterone that the mom's body is making. And we use this in normal obstetrics all the time. Somebody who had a pregnancy and a miscarriage, she probably has a condition called luteal phase defect, and she's losing pregnancies because she doesn't have progesterone. Standard of care, we give these ladies progesterone. When a woman has IVF and they're taking embryos and they're transferring these embryos to the inside of the uterus, she wasn't expecting special guests. She's like, who the heck are these people that just showed up? So what's the standard? Whenever a woman has IVF, she receives progesterone to keep the pregnancy going. We just give these moms progesterone. We're successful about 63% of the time. I've tried this 28 times. I've been successful 22 times out of those 28 times. In fact, there's the first baby that I actually delivered after the mom had made a mistake, looked for help and said, I took the abortion pill. My boyfriend and I regret it. Is there anything we can do? We spent $109. Whenever I'm reversing the effect of the abortion pill, my wife and I pay for it out of our own pocket, but it cost about $109. So anybody who is looking for an investment, you can save the life of maybe 63% of the time for $100. I consider that a great return on investment. But this was a couple. In fact, they called me through our hotline while they were still at the abortion clinic in Mobile, Alabama. It was June and it was 95 degrees. They hadn't even started their car, but they thought that this was going to be the solution. But they got out back to the car and they had immediate regrets, and we were able to help them out. But I like follow up. That's that same baby that had a 98% chance of dying And the grandmother sent me this picture. That's her when she was in, just about 2 years of age. That's her starting kindergarten. Her name is actually Journey because she had a heck of a journey. That's her starting kindergarten at in Mobile, Alabama. She had a 98% chance of dying, yet with a little bit of science and a little bit of medicine, we were able to save her life. That's her in second grade. That's her in third grade. But then something happens with girls in fourth grade. There's this attitude that kicks in. And so that's her in fourth grade, perfectly normal. When it comes to abortion pill reversal, it's either all or none. You either get a red light or a green light. There's no yellow light where you save the heartbeat, but there's lots of defects. We see absolutely no evidence of that at all. This is our most recent data. 2 months ago, we released the data that we have now successfully reversed the effect of the abortion pill 8,000 times. Each of those hearts has 1,000 people standing, up out in that parking lot. And we've successfully saved the lives of 8,000 babies. So when is life created? I mean, we're here to defend life. When do we have life? It's at that moment of conception. If you don't know this guy, he's on YouTube and he's one of my favorite animators and bioethicists and describers of anatomy, where you have one sperm, and this one sperm, it took 40 years to see the process of conception, to understand it. Or how does one sperm get in and no other sperm get in? Because there's something called a zona pellucida 3 receptor, where, and the moms now, we are learning even more recently, where moms don't just sit there and the egg to sit there and the fastest Michael Phelps sperm gets in. Moms actually, and the egg actually has the option of I choose you, I don't choose you. And it's like, how in the world did they do that? We don't know. But when that one sperm makes it through, and at that moment of conception with the ZP3 receptor and the genetic material goes on the inside, there's a shield that goes up and says, yeah, there might be 200 million swimmers trying to get on the inside, but we can only have one gold medalist. One Michael Phelps is going to get in. Well, how do you keep all these other gold medal wannabes from getting on the inside? There's actually a shield. And when that shield goes up, if you look with the right frequency of light, you can actually see a flash of light. That's the moment of conception in mammalian cells. Well, scientists up at, I guess it was up at Harvard University, mapped out that flash of light. And this is what it actually looks like slowed down. I mean, that's just an amazing propagation of this shield that says, I got my gold medalist. Nobody else gets on the inside. But then we have cell division. We go from one cell to two cells. Every time we're genetically doubling the genetic material. And then we go from 1 to 2, 4, 8, 16, 32, 64. And then we start to develop different systems there for that baby as well. This is an animation that was produced, and I think it's one of the best animations of what actually happens during the moment of conception. So this is a baby once it is implanted in the lining of the uterus at about 2 weeks after conception, and that baby starts to grow and develop on the inside. And here you can actually see the neural plate and the nerve starting to develop. This is 22 days after conception. And we can see this on ultrasound, where 22 days after conception, we can actually see that baby's heart that is beating there on the inside. It's moving its own blood type from the baby through the umbilical cord to the placenta. Everything the baby needs, it's coming from the mom. But we can see the eye that's forming right there. We can start to see that the baby will actually respond to light touch. This is the hand of that baby developing. This is only 6 weeks after conception, where we can actually see the imaging of the neurologic system and the baby's brain. At about 6, 7 weeks, we can actually see fingers starting to differentiate, and you can see the difference. This is the miracle of cell differentiation and fetal development. This is going to be about 8 weeks along, and here's about 9 weeks from the last menstrual period, but 7 weeks in conception, and you can see that baby on the inside. Mom might just be starting to think that there might be a pregnancy and she might be pregnant, but she doesn't know for sure until she has an ultrasound. Here you have it about 8 weeks after conception. You can see the lips actually forming, and you can see that eye. And this is not AI. This is AI is when you give parameters and you say, AI, tell me what's going on. This is actually from ultrasound imaging and fetoscopic studies. And this is 10 weeks after conception, where you can actually see fingers and toes and fingerprints, but this is still within that gestational age when the abortion pill can be used to kill a baby there on the inside of the womb. So here's the question. Can we win? I mean, we're here trying to defend life. Life is cool. Life is great. I enjoy life. I like spending time with my family and my friends. I love seeing the world. Life is precious. What can we do to win? Well, my job tonight was to try to give you some new tools that we can all use as a body. I mean, you look at my body, I've got about 60 trillion cells. Are they all exactly the same? No. I've got red blood cells. About half of my 60 trillion cells are red blood cells. Their job is to take oxygen to where it needs to be and then remove carbon dioxide. And they live for about 120 days and then they die. But there's the heart, there's the lungs, there's respiration, there's contractions. If I wanted to jump up and down, how many of my cells got involved in me jumping up and down? Pretty much all of them. Some are carrying oxygen, some muscles are contracting, some are relaxing, some bones are involved in this. But when we partner together, just like we're trying to do tonight, and I appreciate all of your attention, that's when we partner together. My job is to take my skills and my knowledge, give them to you so that when you have a friend or a colleague or even a coworker, you don't want to just say, hey, I'm pro-life and have it end right there. I want you to be able to articulate why you are pro-life. This really comes down to patients' rights. So if we can diagnose, treat, and cure babies in the womb, then they are clearly a patient and they're genetically unique from that moment of conception. And when you look at abortion now, it's about 1.2 million babies each year are being aborted just here in the United States. And when you look at the abortion pill, which was invented by a guy named Etienne Emile Ballou, and it was approved in 1980. He was a Frenchman, and it was initially only approved in France and in China. But when you look at the worldwide explosion of the abortion pill, this guy's invention from 1980, when it was first approved, is probably responsible for about 1 billion lives overall. We only have 8 billion people on the planet. So that's just a Holocaust that's happened on its own. But yeah, you guys were great. Any questions I can help y'all with, I'd be happy to do
Yeah.
it.
Thank you so much, Doctor. And yeah, we usually have a little bit of time to go around the
Yeah,
room, if you will, and just introduce ourselves. And then if they have a
sure.
question,
I'm going to stop sharing my screen and I'll just
okay,
talk to y'all
sure.
like we normally would.
Okay. Um,
Sure.
Let me go ahead and start with Johnny.
Hi, good
Welcome to the
evening.
group.
Thanks, Jason. So this is my first session. I found Rainbow ProLife Alliance through Instagram and Facebook. This was
Nice to
a
meet you,
very
Johnny.
fascinating. Yes, thank you so much. No, this is a very fascinating talk that you gave because,
Thanks.
I mean, I'm still trying to process everything that you shared because
Yeah.
it's not very often that I, talk to friends or my spouse or whoever and have these kinds of conversations that are so medically based. My spouse is actually a nurse, and not
Yeah.
once have I ever, heard from him any of these things that you mentioned. So, and it's just astounding to me that this is where we are with technology. I'm just blown away, and I'm just speechless. So, really, thank you so much for sharing all this. I
You're
really don't have
welcome.
any questions. If anything, I'm just going to do more research on
Sure.
YouTube, watch more videos. But no, it was really
Oh,
enlightening. So
yeah. Yeah, you can go to YouTube and just put in fetal surgery. You will
yeah,
be drawn in, and next thing you know, you'll use 3 hours of your life that you could have used for something else, and it's like, oh my gosh, I had no idea. We just covered a few of the things. There's something new every month. I mean, the technology is just exploding.
that's
Nobody
astounding.
has done a
Yeah,
nobody has done a robotic case, but give us toys, and we want to use toys. Everybody loves the new toys on the block. So, nobody's done a robotic case, but it's coming. But we didn't even scratch the surface. I just wanted to give you some of the highlights. How, yes, a baby in the womb is a patient, and we are now diagnosing, treating, and actually curing babies in the womb, and they have rights.
Thank you. Judy.
Hi, nice to meet you because I did kind of get you hooked up with this group. Doctor,
Well,
can you
nice
hear
to
me?
see you, Judy. Yeah, sure
Yeah.
can.
Um, as first of all, I hope that they have some way of, for low income patients, the mothers and the babies, if there any way of helping them pay for this stuff because it's not cheap.
Absolutely. Absolutely. In fact, when we send our patients down to the Texas Children's Hospital for the twin transfusion, all we have to do is have our social worker contact their social worker. And even though they're coming in from out of state, not only do they provide them with access to the health care, they even find them housing. They work with transportation, and there's funding available for this. Some of it is from independent research from these university medical centers, but also state funds. And our patients have been thrilled with the care. They're like, I can't believe they arranged for my transportation from the airport to the hospital and the private transportation. They gave me housing for the 10 days when the baby was going to be recovering from the surgery. And they're like, I'm back home. And so we're going to follow with you. But when we look at the amount of waste that goes on in healthcare and the amount of embezzlement and just sources that should be going to actual patients and not being skimmed off and helping other people. We have the resources. And when it comes to these special cases, we have some really special funding because this is now an area of medicine which continues to expand. And we're really seeing that it's absolutely a miracle. Technology is great, but let's apply that technology in the best way possible. But yes, there is funding available for this.
Also, one
Thank
more
you.
quick question, just
Go
quick, so I
ahead.
don't hold it up.
Yeah.
You know that the abortion pill, that's why
Yeah.
I'm also Jewish pro-life, that was originally used to kill I can't just say Jews, with the people in the Nazi Holocaust, and
Yeah.
they took that and made the abortion pill out of it. That I heard in Jewish
Yeah.
pro-life.
Well, when it comes, yeah, we're huge supporters of life in any country and in any background. When it comes to the abortion pill, it was a company called Host. Host actually was creating mustard gas and phosgene, other gases originally in World War One. And during World War Two, the same company was developing Zyklon B. Zyklon B was the cyanide derivative, which was used in the gas chambers to kill people in mass, Jews there in the Holocaust, and there were over 6 million Jews that were killed that way. Well, after World War II, that company, the general who was in charge, said, we can't have a company with that much power that can just create pills that can get used in a gas chamber. So they wanted to break that company up. They were only able to break it up into 3 different companies and try to diffuse it. Well, one of the companies purchased another company called Roussel UCLEF. And that was the company that they purchased along the way. Well, Roussel UCLEF is actually where you get RU 486. That's where the RU comes from. It's from UCell, UCLEF. And I don't know if any of you worked as a server, but I worked my way through college as a server. And say you had a special on the board, the chef put up and say, hey, yeah, we've got veal scallopini, and everybody's ordering the veal scallopini. Well, what happens when the chef runs out of veal scallopini? What does he say to put up on the board? 86, the veal scallopini. Kill it. Or no more. Let it, it's dead. Well, when it comes to that term, RU 486, I look at it as a question. RU 486 in the life of this baby on the inside of the womb? But the abortion pill has killed probably 1 billion people right now, but it's also harming women. I got a call from Senator Josh Hawley, to go up to DC. And he said, tell me about the abortion pill. I said, well, I'm actually in Phoenix, Arizona. He says, can you be here in DC tomorrow? I'm like, yes. So we caught a red eye from DC to Detroit, from Phoenix to Detroit, Detroit to DC. And that's why we have so much new attention. You saw the Fifth Circuit Court of Appeals saying, hey, the abortion pill is dangerous. And now this will be held by the case held by the U.S. Supreme Court is like, is this going to be allowed to be continued by the FDA? So keep yourselves posted. But the abortion pill, yes, it's killing more babies than anything else, but it's also harming women, and that's not healthcare.
Thank you. Thank you. Andrew?
Yes, thank you so much.
Oh, you're welcome, Andrew. Hey.
Hey, I was just wondering, it sounded like a lot of the hospitals you were mentioning were Texas and Florida. Is the abortion politics having any sort of effect on which
Not really. And we discussed that UC Davis, University of California, Davis, is leading the world and leading the country when it comes to spina bifida corrective surgery. Not only are they doing amazing spina bifida corrective surgery, but on this trial that they are doing as far as using stem cells, they've just in the past 2 years invested over $40 million just in the treatment, excuse me, of spina bifida in the womb. So it is Massachusetts, Boston Children's Hospital is where the surgery was done for the vein of Galen malformation. So it doesn't seem to be Democrat, Republican, pro-abortion, anti-abortion. It's really healthcare, and we are now, advancing healthcare, all across the country. So it doesn't matter if it's a blue state, red state. And I hate when we get divided, because when we get
Well,
divided, then
yeah,
we start
it's
stop
unfortunate
being
'cause-
effective.
Mhm.
And so the more we fight each other, then the less that the people who really need support get that, because I mean, just look how much money we spend on an election these days, billions of dollars for an election. That money could definitely be used in a better way. But when it comes to this fetal care, it's up in Chicago, it's in California, it's in Texas, it's in Florida, but it's in Boston. I mean, it's in Pennsylvania. Children's Hospital Philadelphia, CHOP, one of the most advanced centers in the country. So it really seems to be widely spread. But great question.
We just passed in Maryland, oh, not we, but in Maryland, they just passed a, basically a fetal testing bill that would prioritize basically using fetal tissue before using animals, because that's inhumane, but using human tissue is not inhumane, of course.
And then we were involved in trying to fight the amendment in Virginia that allowed for abortion at any gestational age for any reason. We were just out in Hawaii.
Right.
I spent 8 days in Hawaii, didn't even see the beach, didn't get my toes wet, but I did 26 different presentations while we were in Hawaii. And not only can you essentially get an abortion at any gestational age legally, it's for any reason up to 24 weeks. But then if the mother's health is threatened, then they use the same definition as Doe versus Bolton with health, where health was defined by the U.S. Supreme Court in Doe versus Bolton as physical, emotional, psychological, familial, or age. In fact, there's a program, an advanced training program called Complex Family Planning. I don't know if you've ever heard of that or not. Like I'm an obstetrician gynecologist. So that meant 4 years of college, 4 years of medical school, 4 years of residency training. It took me 12 years to get a job. So I'm not real bright. So 12 years to get a job, but then you can do a fellowship. And a fellowship is additional training after those core 12 years. And you can do a fellowship in GYN oncology, cancer, reproductive endocrinology, infertility, high risk obstetrics, even urogynecology as far as leaky bladders and stuff like that. Well, there's a fifth fellowship now, and it's called Complex Family Planning. There are now 38 programs, and they're trying for a 39th program. In fact, one of the programs is in Hawaii, right there in Honolulu. Complex Family Planning is a 2-year program. And it's like, well, what did you not learn about birth control pills and IUDs during all this training that you've already done? Complex Family Planning, you are fellowship trained and board certified. And the two primary skills that you are taught are, number one, how to perform a late term abortion. It's like, you hear people say, well, late term abortions are so infrequent that you don't have to worry about it. Then why do we have 38 training programs teaching how to do an abortion in the third trimester? The second skill that you're taught is something called a selective reduction, where say a mom goes through IVF and she has quadruplets, and they go, hey, and I've delivered healthy triplets and I've delivered healthy quadruplets, and we have great health care and great high risk obstetrics and great NICUs, and all these kids are doing great. My quads just graduated from the University of West Florida with honors, and they were there on a full ROT scholarship. But when it comes to complex family planning and selective reduction, you have a mom who has been blessed and she has quadruplets. Well, what do they offer? They say, well, we're concerned about preterm labor. So what we'd like to do is take your 4 babies and decrease that down to maybe just 2 babies. It's like, well, how do you do that? Well, what they'll do is they'll take a ultrasound machine, they'll take a syringe, they load that syringe with either potassium chloride or digoxin. And potassium chloride is what we use for lethal injection to kill people. But they'll take that needle, they'll guide it with ultrasound, and they'll pick a baby. Pick baby A, B, C, or D. And they'll take that needle, they'll guide it right into the baby's heart. They'll inject that baby with either of those medications, kill that baby. It's like Sophie's Choice. I mean, how do you ask the mom? Well, I got A, B, C, or D. Tell me two that you don't want to live. That baby's
Right.
heart stops. The baby is killed. And but that's what they are training. That's what they're calling healthcare. So if you are spending 2 years of your life to abort a baby that poses no threat to the mother's life, that's not healthcare. And if you're using your skills and your knowledge to kill two out of the four babies because you're concerned about future preterm labor, that's not healthcare. So tonight, I'm just honored to be able to give you some information. I appreciate y'all so much for standing up for life because this is an issue that it's the least of these. These are the most vulnerable. And our role as adults is to protect those who can't defend themselves. So I just, celebrate each and every one of you for taking a stand saying, I want to learn some new tools tonight. I'm going to not, go out to dinner, have a glass of wine or whatever. I want to learn some new tools. So, but thank you very much to all of you. And Jason, thanks for the invitation.
Yeah, we got one. Marcos, did you have anything you wanted to add? He's our future OBGYN, so
Oh, great.
if he wants to chime
I
in.
will say culturally, it doesn't help that we had these shows like the Octomom and all of that to like make this sort of freak show of like that's what you're going to be if you don't get a selective reduction. Like have this like, the horror story of the
Oh,
Octomom,
I
which
know.
by
Yeah. Go ahead,
And I
Marcos.
mean,
Oh, no, I didn't have anything, but I wanted to thank you for speaking to the group. I've obviously spoken a few times about a certain topics that I'm kind of knowledgeable in, but I'm barely in my well, I finished my first year, so going on to second year. But yeah, uh, I've always been on this journey to figuring out. I've had very complicated cases that I've seen. Um, so they're always not the best, right? But I mean, it's just ultimately like what respect you have for the specific patient. Like if you consider your
exactly.
patient. Um, because I've had, mothers who have like their babies with anencephaly.
Yep.
I've had mothers who are willing to do everything when their baby has a cystic hydroma or a neural tube
Yep.
defect. Um, so there's obviously a lot of complications that can come with that. And a lot of them look very grim and, they're not the best sight. But um, I've been, blessed to see that these mothers are willing to do everything,
Yep.
to see their babies survive. So,
Absolutely.
yeah, it's kind of interesting that we're on this path right now. But,
Yeah. And
I
I
again,
had three patients who had lethal diagnosis where, we essentially knew this baby was going to die. And
mhm,
they were making these decisions and we said, listen, I'm going to be with you during the whole pregnancy. I'm going to be with you during the delivery and we'll provide any kind of support for you, the baby, and any kind of counseling, if you're going to continue this pregnancy. All three said, yes, I'm going to do everything for my baby. I delivered all three babies. All three babies did pass away. But then
mhm,
even at the 6 week visit, every mom said, you know what? Everybody else was saying, abort that baby. Meanwhile, they said, I've already bonded with this baby. I've been feeling this baby moving around on the inside.
mhm,
One was a nurse anesthetist. Her job is to put people to sleep for a living. She says,
yeah,
I couldn't imagine walking into the operating room, feeling that my baby moving around. Somebody else puts me to sleep. Somebody else then removes that baby, aborts that baby, and disposes of that baby. She said, you
mhm,
gave me the opportunity to not only, feel that baby on the inside, but deliver that baby. And she goes, I wish that it was something else that could have been the final outcome because her baby had trisomy 18, all sorts of birth
mhm,
defects, and the baby died. But she goes, I will forever be grateful because me and my family were able to hold that baby, kiss that baby, love that baby, and we'll never forget that. And so my wife, my oldest daughter, and myself actually attended that baby's funeral. We honored
mhm,
that life. Do I wish that the outcome had been different? Absolutely. But God forbid that we take the easy way out when it comes to healthcare. Sometimes the harder way is the best way, and that's what we want to instill in medical students.
And
And
I just
as
don't
you're,
understand sometimes because, like, when you're talking about late term abortion, like, it's labor and delivery. People don't understand how barbaric that whole process is, and to put someone through that, as opposed to like putting them through, like, inducing labor early if that's the need, or, you know, performing a C-section, right? Like if there's a specific
Mhm.
urgency.
Yep,
But when you have a late trimester abortion, it's labor and delivery, and you're not delivering a baby that's alive. You're delivering a baby that's dead. So I don't know how that can be compassionate in any way to put a woman through that horrific scenario.
I agree with you
Um,
100%. And
because it's just
one
more
point for you,
barbaric in my
Marcus.
eyes.
Oh, you're absolutely right, Marcus.